Good afternoon, and thank you very much for that kind invitation that I could hear behind the curtain, Becky. I appreciate that. And thank you to everyone who's here. I'm happily surprised it's an overflowing crowd. I think that has to do with the topic and the timeliness, I think, of Zika. As an infectious disease and public health physician, I'm always asking what's next and trying to learn from what came before. But what's here now is what requires our attention the most, I think, and what is imminent, which in this case I think is Zika. Ebola is not gone. Middle East respiratory syndrome, MERS, is not gone. It's becoming even worse in the Middle East and outbreak in Korea this summer. But Zika is coming, and it's widespread in Brazil and in Colombia and becoming more widespread in Puerto Rico. And there will always be something next, and I'll allude to that, what I think is next. One of the last slides. So I'd like to speak for about half an hour and then take questions for about half an hour. And what I'd like to do is try to compress my 38 years since I started medical school into 3 lessons, 3 words, 3 verbs, and here they are. Anticipate, recognize, and act. And I'll give examples from different outbreaks, from Ebola, West Africa, Zika, and microcephaly, which, as you know, means small head. But why is the head small of the fetus? It's because the brain is very small, because the brain has been damaged by the Zika virus and doesn't develop normally in utero. And then, I guess I gave away the secret. What's next? What I'm watching closely now with a lot of other people is a large yellow fever virus outbreak. In Angola, it's spread across the border into Democratic Republic of Congo, or DRC. I do want to emphasize that the way that Zika virus is spread is the same way that yellow fever virus is spread by a specific species of mosquito called the Aedes mosquito, which is different than the mosquito that spreads malaria. That's the Anopheles mosquito. Also, in my opinion, although I have to say the world hasn't caught on, but in fact, I'm the only person that's using this term right now, but you heard it here today first. Instead of microcephaly, I think the term should now be changed to Zika neurological syndromes, or ZNS, because Zika affects the nervous system. And as I mentioned, that's why the head is small. That's why I have microcephaly, because of the damage to the brain. And why I think this term is appropriate and defensible right now is because just this month, both the World Health Organization on April 7th and then last Thursday on the 13th, the U.S. Centers for Disease Control and Prevention in Atlanta officially stated that Zika virus does cause microcephaly. Up till now, it hasn't been officially declared as a cause because it was thought that, and I agree, sufficient scientific evidence wasn't available. But now the evidence is available from studies in Brazil and elsewhere, and Zika causes microcephaly because it infects cells of the nervous system. So I think we could call the epidemic Zika neurological syndromes, or ZNS. So the first example I'd like to give of anticipate, recognize, act one, if you will, is from Ebola in West Africa. I was very fortunate to be able to work in Sierra Leone in August of 2014, taking care of patients and working with the Ministry of Health, training nurses and doctors on how to put on and safely take off the so-called Ebola personal protective equipment, or PPE. And I did that only after working in the large hospital in Connaught Hospital in Freetown, the capital of Sierra Leone. And then soon after, I was able to go to work for Doctors Without Borders, or MSF, Médecins Sans Frontières, in Liberia from October 3rd to November 14th for those 6 weeks. With regard to the anticipate part, before I went to West Africa to work with patients with Ebola, what I'd read in the textbooks, what I'd read in the medical papers, what was in all the books, what everyone that I know of thought about Ebola is that most patients died, and they died because of extensive bleeding or hemorrhage. But when I got there and saw a lot of patients, more than 200 patients altogether in Sierra Leone and Liberia, what I recognized very quickly was, in a sense, good news. If there's any good news about Ebola, and there's not really, but if there was good news, or less bad news, I should say, is that death is due to dehydration instead of hemorrhage. So everyone has a little bit of bleeding, in the vomit or the diarrhea or red eyes, but that doesn't kill you. It's the dehydration that kills you. But in a sense, what I say that's good news, because we should be able to treat dehydration. You don't have to help the patient become totally normal hydration status, just not real dehydrated to a point where we call go into shock, and then the heart and the lungs and the brain stop working and the kidneys. So the act was to implement a new policy whereby we were able to hydrate our patients better than before. It was a very difficult time in the beginning of October in Monrovia in Liberia at the Doctors Without Borders Hospital, which I say hospital, but really what it was 10 tents with a mat, like a gym mat or a yoga mat on the floor of the tent. That's what each patient had. There was no intravenous fluid to hydrate them because it was felt that, and it was true, that we had so many patients that we couldn't hydrate all of them intravenously, so it was decided that ethically we couldn't, or we shouldn't, or we wouldn't give intravenous fluid to anyone, except for there were 2 women who were pregnant, and that was the only exception. This is 136 patients, 3 doctors, and many, many brave and extraordinarily hardworking Liberian nurses and nurses' aides. So no intravenous fluid, so now you have a disease where you die of dehydration. It doesn't happen in the United States, right? That would never happen. All the people with Ebola who came to the United States, who got flown back, healthcare workers, for example, they all got intravenous hydration. If their kidneys stopped, they got put on kidney dialysis. If the lungs stopped, they got put on breathing machines. And almost everyone lived. There's no kidney dialysis machines. There's no ventilators in the 3 countries in West Africa where the outbreak was. So you have to keep the patients hydrated enough so they don't go into shock, because then they'll die, for sure. Particularly babies. Who's going to be able to help the babies? Because you can't go in unless you already have it. You can't be inside the treatment area unless you have Ebola yourself. And if I have Ebola and my daughter has Ebola, I'm going to be so weak that I'm not able to help her get hydrated. So who's going to help her? So babies are really at highest risk for dying of Ebola. But it's because of an inability to hydrate. It's not because of hemorrhage. And this brings back a lot of memories for me. This was a PBS Frontline documentary. I highly recommend it to you. May 5th of 2015. May 5th, 2015. But it was a retrospective from the beginning of the outbreak in the forested region of Guinea in December 2013 up until September of 2014. And this was taken from inside I call it mats in the tents hospital, where I worked as of October 3rd. So these are 2 healthcare workers wearing their Ebola personal protective equipment with a bottle of, it's water until you put special salts that contain simply sugar, sodium, and potassium. It's called oral rehydration solution, ORS. It was developed to save the lives of patients with cholera. It turns out with Ebola, you have extensive diarrhea and vomiting. So ORS was a life-saving specific treatment for Ebola, particularly when you couldn't give intravenous fluid. ORS saved many patients' lives, but you have to be able to drink a lot of it, and you're profoundly weak with Ebola, so you actually can't lift the bottle when you first come into the mats in the tents treatment facility. So you need help to drink a lot. And if you don't get it in the first day, 2, 3 days, you're very likely to die. After 6 or 7 days, you're strong enough, you can start to drink on your own, you're very likely to live. It's a crucial, crucial time, first few days. So this was the act. October 11th, after I'd been there for a week, it occurred to me that we needed to be able to help patients survive by helping them to drink enough of the oral rehydration solution. That was the life-saving treatment. And so working with some Liberian colleagues, and we hired a Liberian artist, we came up with this 1-page guide, 4 steps to help our patients survive Ebola. And the bottom line was we gave medicines to stop the vomiting and to stop the diarrhea, and then we did our best to help the patients drink more and more oral rehydration solution. But in the end, we weren't able to do it enough because we were wearing that heavy equipment, and the Doctors Without Borders rule was you could only work for 45 minutes in the morning and 45 minutes in the afternoon. So remember I mentioned 136 patients, 3 doctors? So to do the division, it's 46 patients, 45 patients per doctor. So it's 1 minute per patient. You can't drink enough. You can't help every patient drink enough during that time. So we had to overcome that apparently insurmountable obstacle. And really there are 2 ways that it was overcome. One is through the incredible help of, there are over 600 Liberian healthcare workers working in this facility. Day and night, started in August, most of them worked until February or March. We came and went. They'd say, well, you can only go for 4 weeks because you get too tired. It's like, well, how about our Liberian colleagues? They don't have the option to leave. And this was the most important step, in my view. Because we could only go in for short periods of time for each patient, we asked the patients who were recovering, but not totally recovered. They weren't survivors. They still had some virus in their blood, so they still had to be in the area with the tents. But they were strong enough to eat and drink on their own, to walk around, to ask for new batteries for the radio, for example, and better food. I said, that's a real good sign. If you want better food, that means you're probably going to get better. You're going to recover. You're going to be a survivor. So I called them pre-survivors. And often it took 7, 8, 9, 10 days for the virus to go away from their blood, for their immune system to take it away. And so during that entire time, they were able to take care of themselves. So one day it occurred to me when there were several babies, all of whom were going to die very quickly, meaning hours or a few days, to ask some of the pre-survivors to go back into the tents, because everyone got out of the tent if you could, because who wants to be in the tent? And they had come from the tent, of course, so they knew what it was like to be in the tent. So we asked them, would you go back in and help baby Ben in tent 3, mat 7, to drink oral rehydration solution? And I would say that 80%, 8 out of 10 pre-survivors said, yes, I'll do it. And that's what made the difference. And of course, after one day, one of the Liberian nurses said to me, but Dr. Dan, they call you by first name, why are you only focused on the babies? What about grandmother? What about the 18-year-old man who can't sit up, who can't drink? Let's have the pre-survivors go in and help them. Oh my God, why didn't I think of that? And it worked, and it worked. It was the most rewarding experience I probably ever had in medicine. And so a lot of people started to survive. This is called the survivor's wall. You've probably seen pictures of this. People survive, they put their hand in paint, they put their handprint on the wall, and they put their name if they want to. These are some of the patients, including the children. We gave all the children a stuffed animal when they left. We gave them stuffed animals while they're inside, but everything that's inside the treatment area, the so-called hot zone, stays and gets burned. Everything gets burned. Fires are always burning day and night, day and night, day and night, despite the rain. It was rainy season. And the nurses, it's a joyous experience when patients survive, joyous for everyone, including for the healthcare providers. And again, I want to emphasize that for children, they need extra help to survive because they can't help themselves and there's no one there to help them. Because their family members who might be there, if they're still alive, are often too weak themselves to help their loved ones, which you can imagine the terrible emotional toll that would take. So this is one of the children, a 5-year-old boy who we all thought was going to die, but he didn't, because 2 pre-survivors helped him, and neither of them knew him prior to being in the same tent, in nearby, if not adjacent, mats on the floor of the tent. And when a baby survives, or when Abdullah survives, it's an incredibly energizing, thankful time for all the healthcare workers. And we had a special ceremony when children and adults survived Ebola, very special ceremony. And it was special for us as well as for the patients. This is baby Ben. His grandmother had started taking care of him, and then she became so sick that she couldn't take care of herself and looked like she would die of Ebola. Ben survived, and eventually his grandmother survived, which is just wonderful. And then she came back to take him home. So moving on to Aedes and Zika. Why I spent the amount of time I did about Ebola is because it had a profound effect on me. I'm a clinical doctor for the most part, so I take care of individual patients, and that's what I'm very happy and honored and pleased to be able to do for my career. But I never thought that I should sort of raise my voice, if you will, through the media or through medical literature to call on change by the World Health Organization or by any other organization in the United States or otherwise. But that changed because of Ebola, because I saw decisions that were made at WHO headquarters in Geneva or in Washington, D.C., or in Atlanta, headquarters for Centers for Disease Control and Prevention, or in London or Paris or anywhere else, has a direct, profound impact on what happens on the ground, if you will, at the outbreak site. Sierra Leone, Liberia. So I visited Guinea later, but not, this was in 2015, and I wasn't involved with patient care there. So you heard a little bit in the introduction, so I'll move on to where I'm getting to. But I want to emphasize again that Aedes mosquitoes infect humans, us, our species, with these 4 virus species. Zika that we know about, dengue, which is very widespread in the Americas and in parts of Africa and in Asia, parts of Asia. And then the yellow fever virus that I mentioned is now taking off in Angola and Democratic Republic of Congo, and some Chinese travelers who've been in those countries go back home, they have yellow fever with them. And then another virus that has an unusual name called Chikungunya. It appeared about a year before Zika in the Americas, in December of 2013. And it has infected about 2 million people in the Americas, but very, very few have died, and it doesn't affect the fetus. So you don't hear so much about it. This is a picture from a Brazilian newspaper from February. I was there February 9th to the 16th, so I saved all the newspapers, brought them home. And this is a picture from the street in Recife in Pernambuco State in northeast Brazil. And what it emphasizes is that there's water everywhere. And there's old boots, there's old bottles, there's tires, and it rains. So there's always water, which means that the mosquitoes can breed, and then they can transmit the virus from person to person via the Aedes mosquito. So to some extent, outbreaks of Zika and dengue, or of any Aedes transmitted virus, are linked to the socioeconomic status, to poverty. Because if you can avoid the mosquitoes by working in a air-conditioned office or living in an air-conditioned home where you can close the door, the windows have screens on, the mosquitoes can't come in, then you're not going to get Zika or dengue or yellow fever or chikungunya. So, anticipate, recognize, act 2. The anticipate part was that I was very concerned that there would be epidemics of microcephaly, or what I call now ZNS, or Zika neurological syndromes, in every country where there had been Zika 7, 8, 9 months earlier. So it's the timeline of pregnancy that leads to the appearance of the epidemics of microcephaly, following 7, 8, 9 months earlier with the outbreaks or epidemics of Zika. And at first, mostly we heard about Brazil because so many people were infected, it's such a large population. And so for me, the question was why. This is now early January, and I'm asking myself, why Brazil? Why Brazil? Zika's been around since it was discovered in 1947 in Uganda. It's never been linked to microcephaly before, at least not in Africa. So why now? Why Brazil? And there, you might have heard different theories. Well, it's some pesticide use, well, it's malnutrition, well, it's you have to have chikungunya and then dengue and then Zika to have the damage to the fetus. I don't think any of those things are true, but they're reasonable hypotheses in retrospect. So I started reading and talking to people, and then I decided to walk into the Pan American Health Organization, or PAHO, which has its headquarters in Washington, D.C., to walk in and ask someone without an appointment on a Friday afternoon at 4:45, why Brazil? And fortunately, someone was willing to talk to me. And she said, it's not only Brazil. For me, as an epidemiologist, infectious disease, public health physician, that was the major branch point for me. If it's not only Brazil, then where else and when? It was before Brazil, about a year earlier in French Polynesia, so far, far away. What that meant to me was, it's not pesticides in Brazil, it's not malnutrition in Brazil, it's not anything specific to Brazil, it's about the virus. Because Zika virus caused secondary epidemics of microcephaly 7, 8, 9 months later in French Polynesia, a very far away country. And so for me then, the act was to write a paper with a law school, a very well-known law school professor, Larry Gostin, in the Journal of the American Medical Association, JAMA, which came out on Wednesday morning at 10 o'clock, January 27th. Made a big impression, you can tell in my recollection of the time. We called on the World Health Organization, or WHO, to convene their emergency committee to consider whether Zika and microcephaly should be declared a public health emergency of international concern, which has a very specific medical and public health and legal meaning. And it helps to galvanize the entire international community through WHO and Geneva headquarters. And it's what happened with Ebola, but not till quite late in the Ebola epidemic, not until August 8th of 2014, when the Ebola epidemic was first officially recognized and declared on March 23rd, about 4.5 months earlier. So already there were over 1,000 patients with Ebola before that committee met, and the WHO committee met. So it was very, very delayed, and I felt that the same thing was happening with Zika. That is the delay in convening the committee. So we published this article, and it turned out the media was very interested, and it was translated into multiple languages around the world. We were asked to give a number of interviews. And this is just the documentation of what I mentioned earlier from French Polynesia. It's French, so this is their Ministry of Health report, which said that back in the 24th of November of 2015, French Polynesia health officials reported to, this is a World Health Organization in French, that they'd had this outbreak of Zika followed by microcephaly. So World Health Organization knew this. And I should have known it because this was posted on their website of French Polynesia. But I don't read that every day, and now I do, but I needed to have read it back then. So I didn't know about this till January, thanks to the doctor at Pan American Health Organization late on a Friday evening. So one thing I did was to list every country that had Zika outbreaks and the date officially when they were reported to have Zika outbreaks, and then added 8 or 9 months, and said by this time, if Zika really causes microcephaly, then all these countries will have outbreaks of microcephaly. So it's not going to be just French Polynesia and Brazil. It's going to be 25, or now it's 30 or 35 countries, which is, it's frightening to me. But if it's reality, then if this is what's coming, then we have to do what we can to prevent it or to mitigate it by taking measures against the Aedes mosquitoes, for example, because there's no treatment for this virus and there's no vaccine for this virus. And there's not going to be a treatment or a vaccine anytime soon, because it takes a long time to develop treatment and vaccines, especially when pregnant women are involved because of the safety concern issues. And so what happened was we published this paper in the Journal of the American Medical Association. We noted that the outbreak had occurred in French Polynesia, retrospectively recognized, as well as Brazil, and therefore we predicted it could occur elsewhere. And we called on the World Health Organization Director General, DG, Dr. Chan, to convene the emergency committee. And I'm sure it wasn't only because of this one paper or any interviews, but Dr. Chan on January 28th said she would convene the committee, and she did on the following Monday, February 1st. And the committee of 17 people voted unanimously to declare the microcephaly and other neurological problems, Zika neurological syndromes, if you will, a public health emergency of international concern. And since then, I think WHO Geneva headquarters has done a great job in terms of galvanizing international effort to fight Aedes mosquitoes and Zika. But again, anything you do to fight the Aedes mosquito not only helps against Zika, but against yellow fever, against dengue, and against chikungunya. And who knows, if it's some effort or some successful effort against Aedes mosquitoes, maybe it'll translate into other species of mosquitoes, like the Anopheles mosquito that spreads malaria. And again, as I mentioned, it's only been earlier this month that the World Health Organization and the US Centers for Disease Control declared that now there's enough scientific evidence to say that Zika virus actually causes microcephaly and the associated neurological problems in the fetus. And World Health Organization also said on April 7th that Zika causes an autoimmune neurological disease in adults and children called Guillain-Barré syndrome, or GBS, of which there are other causes as well, but now this is another recognized cause, Zika is. So I was very fortunate then, soon after the end of January, to to go to Brazil, and I try to go to outbreaks as quickly as I can, and to meet colleagues who have been on the front lines, and to learn from them and to share whatever I can about other outbreaks or anything that I can share. So I teach my students is you have to be willing and able to give something of value in order to receive something of value from your colleagues overseas. So this individual and this physician, they work together. She is a pediatric neurologist, as is her mother, who's still practicing, in Recife in northeast Brazil, which is the epicenter of first Zika and then of microcephaly. And this Dr. van der Linden and her mother are two of the very first healthcare workers to recognize the microcephaly epidemic. And the story you may have seen, she's been quoted multiple places, including New York Times, that said that she said that she has worked there many years, and her mother even more years, and they might see 4 or 5 children a year with microcephaly, because there's other causes of microcephaly, rubella, cytomegalovirus, parasites, and alcohol, other reasons. But now they would see 4 or 5 babies a week after week after week. This is early September, October, November. So Brazil actually declared on November 11th a national public health emergency due to microcephaly. They said we don't know what it's due to, but very soon after, by the 17th of November, Brazil had started to test for Zika, and they found the virus in the amniotic fluid of 2 women who were pregnant, whose fetus on ultrasound showed microcephaly. And so the latest update, WHO puts out an update every Thursday afternoon, so 14th of April. Now there have been 6 countries that have Zika-related microcephaly. So not only is it not only French Polynesia and Brazil, it's also Colombia, Martinique, Panama, Cape Verde, which is an island nation in West Africa, not that far from Sierra Leone and Guinea-Bissau and Guinea and Liberia. Brazil now has confirmed over 1,100 cases of microcephaly or Zika neurological syndromes. There have been at least 2 babies born with microcephaly whose mothers were infected outside of the United States. For example, one who came to Hawaii in January after vacationing in northeast Brazil and got infected, and baby was born with microcephaly in Hawaii. So as terrible as it sounds, the spreadsheet, if you will, that I showed earlier with a list of all the countries, the dates when Zika was documented, and then just add 8 months, add 9 months. In my view, it's the nightmare's coming true. In other words, country after country after country. And you can predict when the epidemic wave of microcephaly is going to occur based on when the epidemic wave of Zika occurred. And the time difference is the timeline of pregnancy. Act 3. I mentioned Cape Verde or Cabo Verde. It's a Portuguese-speaking nation, obviously, as is Brazil, as is Guinea-Bissau and West Africa. And they reported an outbreak of Zika involving over 7,500 people last September. It turns out it really started in August. But a lot of people said that, well, there's 2 strains of Zika, one African strain, and that never causes microcephaly. We never heard of that. And the other, there's the Asian strain, which is what's in Latin America. And although today there's still no published proof about which strain it is in Cape Verde that's caused the Zika outbreak since August, it's middle of April. Why don't we know? It's a separate question, but we don't know what strain. My view is it probably doesn't matter. And operationally, we should act as if, whether it's an African strain or Asian strain in Cape Verde, we should monitor very closely and prospectively for microcephaly. Because maybe microcephaly occurs only in a small percentage of the fetus of a mom who's infected in the 1st or 2nd trimester. And so maybe it's always occurred at a low level for 50 years in Africa. We just don't know. Or maybe it's the Asian, Latin American strain of Zika in Cape Verde. Maybe someone got on a plane from Brazil and went to another Portuguese-speaking country. Maybe. And so that's what I was anticipating. There'd be microcephaly outbreaks in Cape Verde. And basically what I said is we need to monitor for microcephaly. Cape Verde, with help from the World Health Organization in Geneva. And so I wrote another paper, this one by myself, calling on WHO to work with Cabo Verde to monitor for microcephaly. This came out on March 17th in a journal called Health Security. This is the paper. And what I'd like to note here is that the paper came out March 17th. The outbreak of Zika had started in August. And by true coincidence, on March 14th, Monday, the first child with microcephaly was born in Cape Verde. A second child was born March 28th. I predicted that it would be a little bit later, that the epidemic wouldn't start until a little bit later, May or June, based on the calculations. But that's when I thought the outbreak had started in September, October. Of Zika, it started in August. And so by Friday of that same week, the 18th of March, the WHO in Geneva, Dr. Chan, the Director General of DG, announced that she was sending a multidisciplinary team to Cape Verde to help monitor for microcephaly. To finish up Act 4 and 5, more generally, I think that part of World Health Organization reform, which everyone agrees is necessary and has already begun after the terrible catastrophe and tragedy, what the United Nations has called Ebola preventable tragedy. There's calls for WHO reform, for example, because they didn't convene their emergency committee until 4.5 months into the outbreak of Ebola in 2014. So what I was concerned about is that there would be delay in convening future emergency committees for future outbreaks. And what I recognized was that there had been delays in convening these committees for Ebola in 2014, and then, in my opinion, and I feel even more strongly so today, for Zika, not until February 1st. Even though we knew about French Polynesia, well, WHO knew, I should have known, but I didn't know, at least going back to the end of November, to November 24th, 2015, when French Polynesia reported that their Zika epidemic of 2013 had caused an epidemic of microcephaly in 2014. So there were just those two countries, French Polynesia and Brazil, with a link between Zika and microcephaly as of November 24th, and as of February 1st. That hadn't changed. So one could argue, and historians might, that the emergency committee perhaps could have or should have been convened earlier for Zika before February 1st. So the most recent article that I wrote that you might have seen, it's online on the United Nations website. They invited me to write it, published April 7th. And basically the final sentence is, I suggested that maybe the responsibility to convene the emergency committee for an outbreak shouldn't be left just to one person. And that's the way the rules are. It's only the one person, the top person, the director general. I think it's too much responsibility for any one person. And the evidence for that, I'd say, is look what happened with Ebola, look what happened with Zika. And what's next? There might be delays with the next thing. Perhaps yellow fever in Angola and DRC will come soon. So the last Act 5 of 5 is anticipate that the yellow fever epidemic going on now in Angola and to the north and Democratic Republic of Congo will continue to worsen. Already, as of today, last week, earlier, the World Health Organization's stockpile of yellow fever vaccine is depleted. There's not even enough doses to vaccinate everybody in Angola that will probably need to be vaccinated. What about DRC? In DRC, of course, Kinshasa is not that far away from the border with Angola, and it's a huge population. So if already the stockpile of World Health Organization's yellow fever vaccine is depleted, what are we going to do if there's a big outbreak in Kinshasa or in Lagos, in Nigeria, or somewhere in Asia where there's never been yellow fever and we don't really understand why, because the Aedes mosquitoes there, dengue is there, Zika is there, Chikungunya is there. Why not yellow fever? So no one's immune against yellow fever in Asia. And there have been 10 or more Chinese workers from Angola who've gone back to China and been found to have yellow fever infection that they got in Angola. So if that was to trigger an outbreak of yellow fever in China, that would be a huge problem. So what was recommended last Friday in the journal called The Lancet, not by me, but by true yellow fever experts, yellow fever virus and epidemic experts, like Tom Moneth and others, they suggested that because we don't have enough vaccine, we should just use 20% of the normal dose, 1/5 of the normal dose to vaccinate people. They think, as experts, and I have no reason to doubt them, that using 1/5 of the normal dose would be sufficient to protect people. Of course, you may ask, well, then why don't we use 1/5 all the time? But okay, and I'd say that, okay, but that's still just 5 times as many doses, right? Will that be enough if yellow fever expands, into DRC or into Nigeria? Or there's been occasional cases that may or may not be linked to the outbreak in Angola, in Uganda, and Kenya, and Mauritania, and elsewhere, and as I mentioned, China. So this is where we are today. What's next? Well, I'm glad to answer the question session about what I think is what's next with regard to Zika. What's next with regard to non-Zika is, I think, yellow fever. It's already upon us. And then I always try to remember to keep a separate category that's what's next. It's the unknown. It's the truly never discovered. It's the HIV up until 1981 or 82 or 83 before that was discovered. It's the SARS virus in China from 2003 that was brand new. It's the MERS virus from the Middle East that was brand new in 2012. So there's always something next, and often it's more than one thing. So it's a dangerous world of infectious diseases that we live in. And this is the last slide. So for a capstone, if you will, I know many of the students here work most of your second year on a capstone. For me, a capstone for my career, which is approaching rapidly, is to have an exhibit, a large exhibit on global infectious disease outbreaks at the Smithsonian, the Museum of Natural History. And so just before I went to West Africa for the first time and to Sierra Leone, I made a proposal to the Smithsonian Museum of Natural History, and after many, many meetings, it was approved, and we've been working now for about 1.5 years on creating such an exhibit. And it's going to focus on, surprise, viruses, including Zika, which we just put in late January, Ebola, MERS, the Middle East Respiratory Syndrome. It's going to focus on influenza a lot because it's going to open in March of 2018, which is the 100-year commemoration of the great, awful, worst ever known human pandemic of influenza that swept around the world. The severe acute respiratory syndrome, SARS from 2003, and of course, HIV, the worst global pandemic of our generation. And we're going to have a section that right now it might just be blank, and it's going to be called What's Next. So I'd like to stop here and take questions, and thank you again very much for coming out today, and look forward to talking with you.
Thank you, Dr. Green.
Thank you.
All right. We have time for questions, so please raise your hand. There's a question right back here.
Thank you for bringing us this information. As a medical educator and a respiratory therapist, this is like catnip for me. In Arkansas, I know one of the community responses to viral outbreaks is to spray residential areas with neurotoxins, aerosolized neurotoxins, and I'm a little concerned about that. I'm a lot concerned about it. There's not a lot of research being done on long-term effects. So I was wondering if you had any information on mosquito management in areas that you've worked in. Thank you.
Sure. Well, thank you for the question. I think your concern is shared by a lot of people and throughout the Americas. So I'm a clinical infectious disease, physician that takes care of patients, so I'm not an expert about control measures for mosquitoes, Aedes or otherwise. But this is a tremendously important topic because this is the only or the primary defense that we have right now today against Zika. It's against the Aedes mosquito. So there's been a lot of discussion about spraying, particularly for the Aedes mosquito. They tend to be peri-domestic, so they're just around where we live, where there's water. And they don't fly very far, maybe 100 yards. But if they live where we live and there's no screens on the doors and no air conditioning, it's very, very difficult. Neurotoxins, I think we're all against those, aerosolized neurotoxins. So I think there's specific guidelines that U.S. Centers for Disease Control and World Health Organization and the government of Brazil, the health ministry, have for what to spray and where to spray it. I think there's an additional issue that's bears attention, and it's getting a lot of attention from in Puerto Rico and with U.S. Centers for Disease Control, and that is resistance of anti-mosquito chemicals. So then you have to test the mosquitoes to see if they're susceptible to what you're going to spray. It's what we have to do, but it just makes it that much more complex and problematic to be able to kill or at least control the mosquitoes. The only other thing I want to say is that there are at least 3 and maybe 5 investigational research ways to try to control the Aedes population in terms of genetically modified mosquitoes, so-called sterile male mosquitoes that can mate but then lead to offspring that die, and also infecting the Aedes mosquitoes with a bacteria called Wolbachia, which then prevents those mosquitoes from getting infected with any virus, dengue, chikungunya, yellow fever, or Zika. So what I think is that, and what I hope, is that we're now in a time of emergency, innovation, and hopefully safe breakthroughs in how to defeat the Aedes mosquito and perhaps other ones because of the Zika emergency.
From here.
Thanks. I actually have 2 questions. The first is, how does the Aedes mosquito, a new Aedes mosquito, acquire the infection? Does it get passed through eggs, or does it have to acquire it in nature? That's one question. And the second question is, what would you do about the Olympics?
So my understanding, I'm not an entomologist, but the understanding of these mosquitoes that they have to acquire, it's a female, just like the female Anopheles, that takes blood from humans or other species in order for the eggs to develop. It's not the male mosquito that bites, it's the female mosquito, and they have to get the virus from humans. Or in some cases, there's what we call a sylvatic cycle or an animal cycle, usually a non-human primate, a monkey. Certainly it's well proven for yellow fever virus, and it's suspected, in fact, for Zika. In fact, the virus was first discovered in 1947 in Uganda near the airport in Entebbe in the Zika forest, hence the name, in a monkey. So it can infect monkeys. So it has to get the virus from the blood that has virus in it, or so-called viremia. As far as I'm glad you asked me about the Olympics. Although I want to keep the answer short and non-political, we all know the Olympics are supposed to start August 5th in Rio, not in the Northeast, but in Rio, but there's Zika and microcephaly in Rio. And in September, there's also the Paralympics in Brazil. And there's a lot of concern about that. Personally, I'm going to the Olympics. First time ever, I can get tickets. It's infectious disease history. I'm going to be there, that's for sure, to witness what's going on. And then take appropriate precautions when I come back as a male, which we can talk about. As far as I know, there's very, very small numbers, less than 10 Olympic athletes who said they're not going to go, or they might not go. And I think the government of Brazil, which may be changing soon at the top, will do their utmost with international help from World Health Organization, from the US, from other countries, from Pan American Health Organization, to make Rio as mosquito-free as possible. But I think it's also important, I'm going on too long, it's important, the last thing I want to say is, because this is very important. Zika, now we know Zika can be sexually transmitted from the male, because the semen can have the Zika virus present. And it can be transmitted now, it's been documented, not surprisingly, from man to woman and from man to man. So I will stop there.
Yes, ma'am, question right here.
I work with our local health department, our state health department, and we are working very, very hard with Zika, trying to get the word out to people that we're not going to eliminate every mosquito in the state of Arkansas. And I think there's a lot of misinformation out there about different mosquitoes that we have, and we've got lots of them in Arkansas, and the best way to control this particular one. Arkansas used to have yellow fever years and years and years ago, and we eliminated it with screens. So I think we're a leg up on 50, 80 years ago. What advice do you have for our statewide health department to get the word out to the public better. And by the way, I'm our vector control person for the health department, so I've recently learned a ton about Aedes mosquitoes that I never knew before.
Well, thank you so much for that question. I think the answer is easy. I defer to you and to the health department. But seriously, the risk communication, it's a central top 5 issue, maybe top 2 issue for any and all infectious disease outbreaks. And it's, in my experience, always a problem, especially in the beginning of an outbreak, whether it's MERS in Saudi Arabia, or MERS in Korea, anthrax in Washington, D.C., SARS in China, Ebola in West Africa. It's always difficult. So you need to, the general rule, as you know, is to be as transparent as possible with the most up-to-date information as possible, and be willing to say, I don't know, or we don't know the answer when you don't know, but then if you know it the next day or the day after that or the following week, then you give that information. And otherwise, I tend to look to authoritative sources. So in our country, it's U.S. Centers for Disease Control and the State Health Department, and globally, it's World Health Organization.
Question right here.
We have bug spray. Is there any bug spray that somebody could put on themselves to prevent being bitten in the first place?
Yes, if it's been studied and approved and licensed to protect against mosquitoes in particular. So when I went to Brazil, I probably had more mosquito repellent that contained something called permethrin than maybe anyone. And also, it was summertime in Brazil, and it was carnival time, and it's on the beach, and I was probably the only person that had a hat, long sleeves, long pants, socks, sandals. It's so hot. But all kidding aside, the answer is yes. And again, the U.S. Centers for Disease Control has a very good, I think, Zika web page, and it has sections for healthcare providers, it has sections for the general public, and it has sections on what can I do to protect myself against mosquitoes. So
You have
it's
a
good
question
reference.
right here.
Thank you. This is probably along the same line, but is there anything other than repellent for anyone that will be traveling out of the country or into those areas that you should do to protect yourself?
So I'd say the general principle is avoid getting bitten by the Aedes mosquito. Okay, we realize that. So I only say that because then anything that you might think of that I haven't thought of or I don't remember to say right now that accomplishes that task, don't get bit by Aedes mosquito, is going to protect you against Zika. So wearing what the British call cover-up clothing, they'd asked me to write a paper in the British Medical Journal, and they call it cover-up clothing, so you don't have exposed skin, basically. But also, the Aedes mosquito, unfortunately for us, bites during the day. So Anopheles bites more, that spreads malaria, bites at dusk and early morning and at night, so you can sleep under a net. But this Aedes mosquito, it bites during the day, so that makes it tougher to avoid. So if you can stay in a enclosed building or office that's air conditioned, that has screens, or that there are no Aedes mosquitoes, that's great. Then you still have to walk to your car or take the bus home, so it's whatever you can do to prevent getting bitten. So it's the insect, it's the mosquito repellent, it's covering up, it's staying indoors in a protected environment, by screens, air conditioning. Those are some of the specifics within the bigger umbrella of don't get bitten by an Aedes mosquito.
Mr. Mann, you had a question back here. Yeah. Did you have one? Yeah.
Do the antivirals not work against these viruses?
No, ma'am, they don't. I try to stay short, but I never succeed. So let me just go a little bit further. Antibiotics are only for bacteria, but No, I understand. No antivirals, yes, ma'am. No, I'm just making the point that, why do I say they don't work? Because antibiotics can treat lots of different kinds of bacteria, and not all, but lots of different. The antiviral drugs that we have that are licensed are much more specific. So the antivirals for HIV, the antivirals for hepatitis C, the antivirals for herpes simplex, they don't generalize. If you can't use them against Ebola viruses or against these 4 viruses, including Zika, that are called the flavivirus, or it just means yellow, I think, in Latin. The antivirals don't work, and we don't have any, unfortunately.
Yes, we have a question. Right back there, we'll get you.
I have 2 questions. My first question is, with it being sexually transmitted, are you now finding, are there studies that are showing that there are cases, is that adding to the microcephaly, or are you finding like miscarriages, an increase in miscarriages? How does that reproductive cycle work for the virus itself? That's the first question. And then the second question is, for those pandemic zones, communication, as you were saying, it's such a large piece of it, and it obviously a lot of fear, I'm sure, when you're on the ground. Is there anything that seems to work really well in those crisis situations to help to communicate both prevention and to get care for the signs? So is it flyers, or is it talking to people? What is that? Because I'm a hospital communicator, so that's a kind of a key thing for me to just interest.
Yeah, absolutely, I understand. So the first question about sexual transmission of Zika virus, this is something that we didn't even know happened until maybe January of this year, but now it's been reported from at least 6 different countries in Europe, in the States, and in Peru and Argentina and elsewhere in Latin America. So to the best of my knowledge, it's only been documented in a small number of those countries, but 1 or 2 or 3. In this country, in 6, at least 6 so far that it's been reported. So it's a small number, and to the best of my knowledge, there's no example given, and I guess you really wouldn't expect it of microcephaly having occurred because of the sexual transmission, because of the timeline of pregnancy. So it's been January, February, March, 1, 2, 3, 4, 5, 6, 10 cases of Zika transmission. And did any of those involve a woman who was pregnant? I don't know the answer. I've read the reports and I don't recall any. But in my view, we should assume that however Zika virus got into the blood and into the amniotic fluid and may have exposed the fetus through sexual transmission or through Aedes bite, it could do the same damage. As far as communication, it's a whole huge topic, and I share your appreciation for how important it is in the hospital and the community. I think it depends on, to some extent, on the type of the outbreak and where it is, but then there's these core principles, if you will, of so-called announce early, tell people what you know and what you don't know in the beginning, and then come back the next day or even 8 hours later if you have significant updated information. Be transparent. Don't say, well, we don't want to panic you, so we're not going to tell you. Well, that panics people, or it can. With Ebola, when I got off the plane August 10th of 2014 in Sierra Leone and Freetown, there were these big signs in the airport that said, Ebola is real. And I took pictures, and I took pictures. It's like, what does that mean? Of course Ebola is real. You've got to understand, most importantly, who's your target audience? Who are you? Is it to a medical audience? Is it a non-medical audience? Is it politicians? And as a medical person, I'm not that good at communicating with people who are not medical, because I start to use jargon and expressions and assume some understanding of germ theory, that type of thing. So I'd say the most important thing probably is understand who your audience is and what language or how to convey your message, your core message, to that particular audience.
Mary Jane, you got one right here.
With regard to the Zika virus, so you explained what happens to the fetus, but say a person gets bitten, how sick do you get?
Thank you. Fundamental question. Thank you. So this is the state of our understanding. It's the dogma as of today. And if there are 10 people who get Zika virus infection, only 2 of those 10 are going to get sick. The other 8 aren't even going to know that they had it, so they have no symptoms. The 2 who do have symptoms, 20%, the typical symptoms are a little bit of fever, not very much. joint pains, but not nearly as bad as dengue or chikungunya. Rash, and this is the key thing that distinguishes Zika. The rash can be across most of the body, but it's itchy. The rash with dengue is not itchy. So at first when the outbreak started in Brazil, and it started in December of 2014, it wasn't laboratory confirmed until May of 2015. Why? There were thousands, more than 7,000 patients reported to World Health Organization from Brazil with this unexplained itchy rash, and a little bit of fever, but not that much, and some joint pain, but not that bad, and some muscle pain, but not that bad. And then some of the patients developed a pink eye or red eye. But almost no one died, and it didn't seem to be anything to worry about. And so it was initially thought to be some kind of an allergic reaction because of the itchiness, the itchy rash. And why did no one think of Zika? Because Zika had never been here before in Brazil or in Latin America. Just like even West Nile virus, when it came to the United States in August of 1999 in New York, we didn't know, we didn't suspect it. We said it was some other virus, St. Louis encephalitis virus. So, those are the clinical manifestations when you do get symptomatic, and the 20% of people who do after they get infected with Zika virus. And then fortunately, the virus goes out of your blood, it's said, in about 7 days, 1 week. And then you recover completely. Except in rare exceptions when your immune system is very weak, of course. And that's it. There's no chronic state, which is really good news. Unlike hepatitis C or HIV or other diseases, certain other viruses.
Dan, let me ask you a question. In terms of, on your chart, you had the countries where and you got to the United States, and there were 2 cases that people had contracted outside of the country. When do you anticipate, if you were guessing, that we will have the first in-country case of this, and where, obviously in the South, Florida, Texas, where do you, any predictions?
So I tried just to follow the trail of the Zika virus epidemic. So I think Puerto Rico is going to be the first. I mean, They have transmission in Puerto Rico now from person to mosquito to person, which we don't have in continental US yet. And that includes a number of women who are pregnant that have been identified that got Zika in the first or second trimester. So then you just add 7, 8, 9 months.
Right.
In the United States, it's always dangerous to predict the future. It's safer to predict the past. But I think, I used to live in Florida and South Carolina, but the mosquitoes, I think, are going to start biting pretty soon. The Aedes mosquitoes, say by June, maybe to be safe, you could say by June. And then if a traveler, let's say I go to the Olympics and I come back and I have, don't know it, I'm one of the 80% that don't know I have the infection, the virus is in my blood for a week, and I'm in Florida to go to Disney World or something, mosquitoes bite my blood, then they can go and bite somebody else. And these mosquitoes, unfortunately, they do a lot of bad things. They bite during the day, but also they tend to be what are called, well, it's not a very nice word. They bite more than one person to get their blood meal. So they could bite 3 people and transmit the virus to 3 people rather than just 1 in the course of getting their blood meal. So I'd say, let's say if it's August that they're spread within the United States, particularly in the southern part of the United States, person to mosquito to person. God forbid, but statistically it's likely that there'll be some woman who's pregnant in the first or second trimester, let's say in August, and then you add 7, 8 months.
Let's thank Dr. Dan for being here.
Thank you very much. Thank you so much. Really appreciate it. Thanks, man. Appreciate it. Thanks.